Okay, and MTAP is a key gene involved in regulating methionine salvage pathway and polyamine metabolism. At ESMO 2024, we reported that MTAP loss was associated with poor prognosis and shorter progression-free survival and immune checkpoint inhibitors. However, underlying biological mechanisms remain unclear. Herein, we present updated clinical outcomes together with transcriptomic analysis to elucidate these mechanisms. We analyzed patients with advanced solid tumor from SCRUM-Japan Monster Screen 1 and 2 study, a nationwide multi-center and genomic screening programs using tissue-based next-generation sequencing. Cohort A consisted of 773 patients enrolled in Monster 1 study, of whom 91 patients had MTAP loss with a prevalence 9.2%. In this cohort, clinical outcomes and treatment efficacy were analyzed, and the Foundation 1 CDX assay was performed. Cohort 2 consisted of 714 patients enrolled in Monster 2 study, of whom 64 patients had MTAP loss with a prevalence 9.0%. In this cohort, transcriptomic data analyzed by Caris MI tumor-seq hybrid was used for deconvolution and gene set enrichment analysis. And the next frequency, in the context of frequency of MTAP loss across various cancer types. In cohort A, MTAP loss, pancreatic ductal adenocarcinoma has the highest frequency of MTAP loss, observed 36.1% of cases, followed by urothelial carcinoma, biliary tract cancer, melanoma, and gastric cancer. Whereas in cohort B, urothelial carcinoma has the highest frequency, observed 36.1% of cases, followed by pancreatic ductal adenocarcinoma, gastric cancer, and HCC. Also, the background tumor type are differed between the two cohorts. The frequency of MTAP loss in most tumor types are generally consistent. Next, we analyze the overall survival according to MTAP status, incorporating the additional follow-up data since we present at ESMO 2024. MTAP loss group continued to demonstrate a significantly poor prognosis with a median overall survival was 14.8 months compared to 37.4 months for the MTAP wild-type group, with a hazard ratio of 2.53. When analyzed by the cancer type, MTAP loss tumor showed particularly poor prognosis in urothelial carcinoma and biliary tract cancer. Furthermore, we re-evaluated the progression-free survival in patients treated with immune checkpoint inhibitors. MTAP loss tumor continued to demonstrate a significantly shorter progression-free survival, with a median progression-free survival was 3.4 months compared to 5.8 months for the MTAP wild-type group, with a hazard ratio of 1.74. This trend of shorter progression-free survival was particularly notable in melanoma. And furthermore, to explore the mechanism of immune resistance, we performed the deconvolution and gene set enrichment analysis using the transcriptomic data from Monster Screen 2 study. The tumor immune microenvironmental analysis using Excel showed the MTAP loss tumor showed a significantly reduced infiltration of CD4 positive T cell and CD8 positive T cell and M2 macrophages compared to MTAP wild-type tumor. And using traded hallmark C1 and C2 corrections of a GSEA gene set enrichment analysis showed MTAP wild-type tumor showed prominent enrichment of transcriptomic programs located on chromosome 9p21 and stronger complement activation and B-cell-related signaling. Importantly, when we focus on the C1 collections, we can observe MTAP wild-type tumor showed prominent enrichment of prominent enrichment of type 1 interferon class genes on chromosome 9p21, whereas MTAP loss tumor showed significantly negative enrichment for these 9p21 encoded type 1 interferon class genes. In conclusion, MTAP loss defines a clinically advanced subset characterized by inferior overall survival and shorter progression-free survival and immune checkpoint inhibitors. Transcriptomic analysis revealed MTAP loss tumor showed significantly reduced infiltration of CD4 positive T cell and CD8 positive T cell, and significantly negative enrichment for type 1 interferon class genes and B cell related signaling. These findings provide a mechanistic context for observed clinical resistance to immune checkpoint inhibitors. These are our key conclusions. Thank you.